And today with me is Adelina, who will help me discuss some of the PowerPoint slides that I prepared for you, and then the cases. Let's move on. And my first slide is a slide of Dr. Lynch, who described these families with increased incidence of particular cancers, and he's the one that has lent a name to Lynch syndrome. This was 1967. I found the original paper. I haven't read it all. Of course, this was long before we knew about defects of DNA repair process. We started to understand and started to have the first descriptions of these type of repair systems in the 70s. But it was really in 1993 where there was a clear link between the mismatch repair system and Lynch syndrome. And these are 4 papers that appeared almost at the same time, 3 in Science and 1 in Nature, that describe the association between microsatellite instability, which was then the only way of understanding whether somebody was mismatch repair deficient, and familial inherited cancer syndrome. 20 years later, or 15 years later, or no, 25 years later, the work around mismatch repair was recognized with the Nobel Prize for Chemistry for Paul Modrich. Actually, I'll tell you a lie, because Paul Modrich, as is custom nowadays, shared the Nobel Prize with 2 other scientists, Thomas Lindahl and Aziz Sankar. So Thomas Lindahl, and each for slightly different endeavor. So Thomas Lindahl was the first notable person that started to tell the world that DNA was not a stable molecule, because until then it was thought to be chiseled in stone and not very much went wrong with it. And subsequently discovered the base excision repair mechanism. And he is a scientist that was born in Sweden, but worked most of his time in the UK. Aziz is a scientist of Turkish descent and worked in the US, and he described the nucleotide excision repair. And then Paul Modrich demonstrated the mismatch repair system. So this gives me the opportunity to tell you that there are 2 different types of damage: a single-strand DNA damage, a double-strand DNA damage, and there are different ways in which it can be repaired. Not annotated here, but maybe in the next slide, there is this thing that, in effect, every time DNA is copied, most of the DNA enzymes that synthesize DNA are proofreading. So if they make a mistake, and mistakes do occur quite quickly, they're also quickly repaired. Fantastic. So proofreading. And this was a slide that I had created some time ago, because the concept was that these are mechanisms to prevent mutation, but actually mutation is the basis of evolution and life. So some people say, well, actually these are mechanisms to facilitate mutations, not just to prevent them. So it's kind of makes this unique. It's a broader way. So in copying errors that escape proofreading, the mismatch repair deals with single-strand repairs, and then there are double-stranded repair system that you are more familiar with now in the context of homologous DNA recombination, BRCA, etc., etc. Yeah, and also to say that a lot of molecules that are involved in these repairs are shared between systems. There are some unique molecules, but some not unique molecules. So this is a scheme of how mismatch is detected, and usually there is a substitution of a chunk of the strand by the mechanism. And what is based on, and you can see how many accessory molecules that are in this system, and you see you recognize ATM, BRCA, RAD50, etc., that poly that are common in other systems. But what is unique to it is the mechanisms to detect, and this is the clamp The mechanism, there is a clamp of two enzymes that run along the DNA and reads the single strand and kind of probably mechanically detect there is something out of place. And then there is another pair that helps the repair, the cutting and the polymerases. So these system, because they were described in non-humans, they are human analogs of mouse, for instance. They're called MAT. MAT-S is the heterodimer that recognizes, and MAT-L is the heterodimer that resolves. And they are made each of two enzymes. And kind of schematically shown here. Don't know what that is. And importantly, the deficiency or mismatch repair has become very prominent because most solid tumors with mismatch repair deficiencies respond very well to immune checkpoint blockades. And also, this is a story that came up about 8 years ago. And so now, any patient in the metastatic setting in second line, so they failed the first best therapy, is eligible to immune checkpoint inhibitor, even if the PD-L1 is low or whatever it is, other parameter, any solid tumor. So that's a kind of has increased the onus on pathologists to identify these cases. So this little fish here, this is a British kind of say, is a red herring. And what is the red herring? The red herring is the microsatellite instability, because for many years we've been talking about microsatellite instability, then mismatch repair was associated with it. But microsatellite instability is only the instrument panel, the LED light that says there is a defect of repair here, you know? Yeah. So in the past, the only way of knowing that was by, if you want, look at these microsatellites and see whether there was instability in them as an indication of mismatch repair deficiency. And the tumors were classified as stable, nothing happens. Unstable low, probably not abnormal, but who knows? And unstable high, MSI high. Now this is thing of the past. We have better tools. Yeah. And now we do talk about deficiency or proficiency.
But I guess, yeah, this is another tool to kind of, people are trying to predict the response to therapy.
Exactly.
We only use high.
And we only use high as identification criteria. So what are these microsatellites? So as you know, the coding regions of the DNA are a minority in respect to the non-coding regions. So microsatellites are in non-coding regions. They are repeats, tandem repeats of very monotonous nucleotides or trinucleotides or peptide, etc., mostly dinucleotides, hundreds of thousands of them. And they, because of the way in which they are configured with this monotonous repeat, they're very prone to errors in copying. So that means that errors are generated all the time. If you have a good mismatch repair system, they get repaired. So the microsatellite region that you are studying is fairly well conserved.
To a certain extent, they're repaired.
To a certain extent, but there is not a huge amount of instability in these regions. But if you have microsatellite instability, these regions will go, will be all over the place. Some will be short, some will be longer, and you will show heterogeneity in an individual's tissue, which is a LED light that will tell us this is a defect here in repairing DNA. Traditionally, we had identified, I don't know why we had this line here, it doesn't matter. We have identified, they had identified particular regions in the DNA. These are the regions, according to Bethesda, there was a meeting there and they agreed on what are the regions that are more useful in providing concordant results. They've been updated variously. And then there is a tendency of say, if there are more than two loci instability affected that we can demonstrate is high. If it's less than two loci,
that is to say that also now we have different loci that have been discovered. Some of them might be tumor specific. We're actually using a different panel.
And we're using a different panel because you know, this was 2004. Maybe these were the best regions to look at. In the meantime, advances have shown different loci were more reliable in demonstrating instability. And then some of these things were patented. So other biotech companies came up with different loci so that they wouldn't have to infringe copyrights, but it doesn't matter. But in reality, these things are kind of things in the past, but they can be useful to resolve some cases where we don't understand whether there is or there is not.
Yeah.
And just let me forward slightly. So this is the way in which they used to test. So you have to compare tumor and normal. And these are the various loci. And you can see here, tumor and normal have the same noise in each one of these regions, in these loci. That's stable. But here you can see there are quite a lot of differences between these. These are quite similar. But here there is a tail that is not there, et cetera, et cetera. So more than 2 loci, this is microsatellite and stable. And this particular thing is capillary electrophoresis after some polymerases work. Okay, so that's how we used to work. But nowadays we have an enzyme. We know that the 4 enzymes that constitute the 2 clumps are very fundamental in it. And most cases will have a defect in these enzymes. And as usual in pathologies, we made a comment yesterday that we don't chase minority things like 0.1% of cases that don't fit into this profile. We are very happy to a 90% or 95% or so. And the greatest majority of cases where there is a mismatch repair deficiency, the defects are in one of these 4 enzymes, and maybe I'll show you another molecule. Yes, we were reading some of the comments which are interesting. Sorry. So nowadays we chase these molecules, these enzymes. You could do it by synthesis. You can sequence it and see whether there are mutations or absences, etc. But actually, immunohistochemistry is reliable. It's actually probably more reliable than synthesis, and certainly is applicable to the volume of cases that we have. So I told you that there are 4 molecules, but there are 5 molecules. The 5th molecule is EpCAM. So let me see if I have a scheme of the molecules. I might have skipped something. No, I don't, but maybe forward, who knows? Yeah, okay. So the molecules, let me see, it's another one. No, the molecules that we are looking at are the molecules that constitute these heterodimers. And one heterodimer is made up of MLH1 and PMS2, and the other heterodimer is made up with MHS2 and MHS6. So we have antibodies against these molecules. If they are preserved in the tissue, you can see the immunohistochemistry. And the theory is that the mutant one probably is not expressed, or if it's expressed, it's degraded very quickly, doesn't really localize where it should localize. I don't see very much. But interestingly, also the partner disappears because they become very susceptible to ubiquination. So they get degraded. So together, they are protected from ubiquination. When they're separated, they are prone to degradation. So essentially, by immunohistochemistry, we lose also the partner. So that's kind of useful. And the other molecules I was telling you about is EpCAM, that pathologists know it more familiarly from the epitope we used to stain for this molecule, which is BERI-P4. EpCAM is a gene that is located just upstream of the promoter of MSH2. And mutations in EpCAM, which are either deletions, translocations, or other mutations, results in loss of expression of promoter, and therefore loss of expression of the MSH2. So if you and genetically, you can have syndromes where the defect is not in this either of these 4 enzymes, but in EpCAM. And if you do have immunohistochemistry where there is lack of MSH2, it may be worth staining, because look how nicely it maps to where there is also loss of MSH2. So you can actually see correlate this quite nicely. So let's see what else happens forward. I forgot. Okay. And this slide is to show you agreement in between the immunohistochemistry for mismatch repair and sequencing by NGS. And you can see that there is very good agreement, 98%, 94%. So these are type of figures where pathologists would love to have. You know, these are very good figures. Okay, we are missing in 1%, 3% of cases, but we're very happy with it. So we can use these things confidently in our practice.
Yeah, but this is to say that it's for colorectal.
Okay, so very good. So now we start the discussion that some of these observations are applicable across board in all solid tumors. Some other observations are very pertinent to particular tumor type. For instance, colorectal cancer, which is the subject of our endeavor today. And in fact, in this context, you know that we put together with the mismatch repair enzyme also BRAF, V600E antibody. And this is just to show you, again, correlation between sequencing and positivity or negativity for the antibody. So it's very good correlation. So the reason why BRAF is important in colorectal cancer, who knows if I have a slide forward? There are. So this is a particular case. For instance, we have loss of one enzyme and preservation of the other enzyme from the other pair, and then a BRAF V600E, which help us determine whether this colorectal case may be syndromic, may be associated with Lynch syndrome, or is much more likely to be sporadic. This is something that happens. You lose the ability to repair, but not because of Lynch syndrome or other genomic syndromes. And the reason why, and this is a kind of, if you want, algorithm that we use, we test for the mismatch repair using immunohistochemistry. If it's proficient, that's good. If it's deficient, we do reflex with V600E, because if V600E is not mutated, there is a question, you know, could this be a Lynch syndrome or a syndromic patient? And you should tell your clinicians to consider a referral for genetic analysis. If there is evidence of mutation, and the antibody in colorectal cancer is fantastic, because 99% of BRAF mutations in colorectal cancer are V600E, you can't mistake it, then it's really unlikely that this is Lynch syndrome. It's much more likely to be sporadic, and therefore there is different consideration for genetic testing. So you see here that this particular case has only two antibodies, one from each pair, and this is the kind of approach that people such as our friend Joseph Rushov has. He says, why testing for both antibodies, molecules in the pair, if they are both absent or both present? Yeah, save two antibodies, you know?
Yeah, logic, at least in colorectal, could sound like a way to go. More logical approach.
But in other tumor types, we need to be careful, because that doesn't really work entirely like this. My approach to these type of problems in immunohistochemistry is that now we're using a single antibody to say yes or no. And I feel uneasy about that, because if there is a failure and I don't recognize the failure, I'm going to provide the wrong diagnosis. So the other antibody gives me confidence. Yeah,
I think we need to be a bit scientific and practical with these things, because we rely on a single test done once, and then of course we
so you know, of course, it's the same things like why do we test for PR in breast cancer? You know, we do ER. Some people don't do PR, ER and HER2, and most of us say, well, we really want to look at the PR. Especially because if I get a tumor where ER is negative and PR is positive, I think, wait a moment, there's something odd about it. So that doesn't make sense. Okay, very good. So we can skip all these things. It doesn't matter. A few slides here to tell you that, as usual, things are a bit more complicated than what they feed us, you know? So there are actually 7 proteins involved in the recognition in these 2 clumps, not 4. 7, and they're listed here. And these 7 forms different pairs, you see, and these are called MAT-S alpha, MAT-S beta, doesn't matter, these are all these. But you can see that MSH2 has an alternative partner. So I wonder what happens if I don't express MSH6. Do I still see MSH2 because he has a partner that protects it? Yeah, so we don't know. And the same for MLH1, because the PMS2 exists, MLHC3 exists as potential partner. So, and I was telling yesterday, every now and again, I go to these conferences where these experts present data on mismatch repair, and then question from the audience, I ask, what about all these other enzymes, and people say, what enzymes? You know, there are 7, not 4. Oh, yeah, we don't test for them. But why don't we test for them? Nobody really has any answers, you know, and that's kind of, we are a little bit superficial, I guess, in our approach to these things. I don't know why we don't test. I don't know why it is not important, but it is likely that some of these partners play a role, a more important role in some other cancers. And that's why what Adelina was saying is, yeah, those are the rules for colorectal cancer, but it's not quite the same in endometrial cancer, for instance, et cetera, et cetera. So keep your minds open about this. Okay, so just a few more slides to tell you how we're doing for time. Not so bad. To tell you that mismatch repair now becomes an important part of the classification of tumors. So this is the molecular classification of endometrial carcinoma. It's in the blue book. First of all, you do mismatch repair using the antibodies. If it's deficient, you find a diagnosis is a mismatch repair deficiency endometrial carcinoma. You stop there. If it's intact, you determine whether there is mutation of poly, and you isolate all the poly-mutated endometrial carcinoma. And if this is wild type, you look for chromosomal instability. And chromosomal instability will require a lot of sequencing, which none of us can do to any extent. But it has been shown that with caution, P53 is one of those molecules that are mutated almost all the time if there is chromosomal instability, and are wild type if there is no chromosomal instability. So in many systems now, P53 status, as mutated or non-mutated, has been taken as a surrogate marker for chromosomal instability. And here come another thing, and I was telling Sarah, we ought to have a circulation for interpretation of P53, because it's no longer what's the percentage of P53 staining. That's not it. We need to identify whether there is a wild type pattern expression or a mutant pattern expression, which could be now, you know, there are different patterns. So our interpretation is here. So this is endometrial carcinoma, and this is the work we've done with Simona on gastric cancer. The same thing is a cascade. First, you do in situ validation for EBAR or for EBV. If it's positive, you identify the EBV positive gastric cancer, good prognosis. Then you do mismatch repair. You isolate those with deficient mismatch repair system. They are treated differently. They have different implications. Then you look at loss of cohesion and look for the markers of epithelial mesenchymal transformation. Use beta-catenin and ecadherin. There may be better ones around. And then if all of these are preserved, you use P53 to separate the instability ones from the from the stable. So you can see here how mismatch repair, determination of mismatch repair status become an integral part of the classification of tumors, which are an integral part on how we treat patients. Excellent. We are in